Good afternoon, and welcome. I can't tell you how pleased I am to see all of you here, splendid turnout. For me, I just thank you all, each and every one of you, for being here today. I hope you find it beneficial on this very chilly Saturday afternoon. I'm indeed Rich Hatfield. I'm the Executive Director Northeast of the Epilepsy Foundation of Florida. Not only do they want to welcome you, but I also want to tell you a little bit about our organization. We've been around for 41 years. We're a 501c3 organization that is the principal agency for epilepsy services and programs sponsored by the state of Florida, servicing an estimated 375,000 Floridians and their families who have to deal with this disorder every day of their lives. We serve as the lead advocate for the rights and needs of people with epilepsy and seizure disorders at every level, local, county, and state. In addition to advocacy, our programs and services include case management, programs and services, information and referral and support, medical services, prevention and education, support groups, and children's camps, to mention but a few. And we have a sizable presence on Facebook and social media. I hope you're there. Our mission is to lead the fight to stop seizures, find a cure, and overcome the challenges created by epilepsy. That's a full plate, to say the least. In addition to the support from our partner for this event, the Mayo Clinic, this public forum is made possible this afternoon by a program known as Project Access. It is a national program funded through the Health Resources and Services Administration, otherwise known as HRSA, to develop comprehensive models of care for children and youth with epilepsy and their families, and to eradicate stigma by increasing public awareness and understanding of the disorder. The parent toolkits and seizure calendars are some of the materials produced through this program. Many of you learned about this event through EFOF's Facebook Parent Support Group. That too is a service of Project Access. The foundation provides specialized case management for children and youth, including assistance with school medication assistance and benefits counseling throughout all of Florida, and neurological care for those living in our service areas. Amongst other things we do is raise money. And I would be remiss if I did not tell you that come on March 31st, Jacksonville will hold its Walk for Epilepsy. It'll be at Memorial Park. It'll be at, which is on Riverside Ave. It'll start at 9 in the morning. And I hope if you can make it, you will come join us for some fun and some fellowship and also a little networking. You'll find information on the walk, our programs and services, and our annual report, all on the epilepsy table, which is across the hall and in the front room here. I hope you'll help yourself to any of those materials. You can always go to our website, www.epilepsyfla.org, to sign up for any of our walks or to get more information. And I encourage you, if you have not, to check out www.epilepsyu.com. You'll find a lot of good interactive information there, and I would encourage you to take advantage of it. If you're not into websites, you can always call us. We have a toll-free number, 1-877-553-7453 for more information. And actually, on the table that I just referred to a second ago, there is a referral form that you can pick up today and fill out in order to start the process of getting services from us.
Can you repeat that number, please?
Sure. 877-553-7453.
Thank you.
You're welcome. We are here for you, but we also need your help. I want to introduce a very special person who has joined us today from South Florida. She is the new Board of Directors Chair of the Epilepsy Foundation of Florida, Novette Green. Novette, if you would stand up so people can see who you are. We thank you very much for being here. And finally, on behalf of our foundation, I want to offer a special thanks to the presenters who were here this afternoon. We know how busy they are, and we really appreciate the fact that they have given up their Saturday afternoon to spend time with us and educating us. I also want to recognize Danielle Deuce, who you've already heard about. Danielle, where are you? Is she in the room? She's left. Of course.
Father is up there.
But Danielle is the individual who has put together this program this afternoon. I want to thank her so much for her tireless efforts in making it happen. And it's going to be a success because she worked so hard at doing that. And Danielle, I know you're probably going to sleep pretty well tonight.
I am.
Yeah.
Thank you very much for coming today. I'm just pleased as a mom. I have a 9-year-old son who has epilepsy, and so this is a wonderful opportunity for me too to meet other parents and care providers and just come alongside everybody and network and support each other. So thank you for coming.
I'm sure I'm missing some people. I should thank the cupcakes you're going to see later on today are contributed to us, donated to us by Virginia College. So we thank them for that. And Dr. Tatum, I think it's time to get this program underway. Thank you.
All right, we're going to go ahead and get started. Thanks so much, Rich. We appreciate everything that you do. So to kick off this scientific program, we're going to start off with a colleague of mine from Nemours Children's Hospital, Dr. Harry Abram, who many of you may know has been in Jacksonville for some period of time. He works in the Department of Pediatric Neurology and knows a great deal on epilepsy. So with that, I'd like to welcome Dr. Harry Abram to the podium.
Very cool. Well, I want to thank Dr. Tatum for inviting me and Mrs. Deuce for putting this together, Mr. Hatfield for organizing this again, and it's great to see so many of my patients here, and it's really a very good event, and I look forward to spending the afternoon with you guys. My objective is to talk about epilepsy this morning, and I'm going to start off with a talk about the basics of epilepsy, a bit of an overview, and then we're going to talk about the effects of epilepsy on growth and development. So let's see if I can get my slides to work here. So these are my objectives this morning. I want to talk about epilepsy in an overview just to educate you so you can understand the rest of the talks this afternoon. We're going to talk about the differences between a seizure, an epilepsy, and what is an epileptic syndrome. We're going to talk about causes of seizures, causes of epilepsy, and then talk about the treatment of seizures. And there are medication options for seizures, and there are also non-medication options for seizures. And after that basic introduction, we're going to talk about the effect of epilepsy on the growth and development of a child. So this is Epilepsy 101. This is the basics. What is a seizure? What is epilepsy? And how do we treat epilepsy? And the slide to the left there is just a picture I found off Google representing a brainstorm, which is one way to think of a seizure, because it's an electrical discharge from the brain. So what is a seizure? A seizure, clinically, to a person that you're looking at or talking to, is a sudden change in awareness, behavior, or a sensation. And it is due to an abnormal discharge of a brain cell, which we call the neuron. And this is just a diagram of the neuron. There are chemicals that excite the neurons and chemicals that inhibit the neurons. And when you have a lack of inhibition or a lack of breaking of the neurochemicals, we have a seizure. So that's the basics of what a seizure is. The manifestations of a seizure depends on where in the brain the seizure is coming from. So if you have a seizure starting from the motor area, you may have movements of an arm or leg. If you have a seizure starting from the sensory area, you may have a funny sensation of an arm or leg. I had a patient once who described seeing ants all over the left side of her body, and we did the EEG. We discovered that she was having a seizure coming from the sensory area of the opposite side of the body. If you have a seizure coming from the occipital area, which is the back of the brain, the visual cortex, you may just have a visual sensation. So a seizure depends where in the brain it's coming from. There are different types of seizures. There are generalized seizures, and generalized seizures come from the entire brain all at once. And there are about 4 basic types of generalized seizures. There are absent seizures, tonic-clonic seizures, myoclonic seizures, and atonic seizures. And I'll go through these again in a second. But those are the major types of generalized seizures. Again, they involve the entire brain all at once. And then there are partial seizures. Partial seizures, we also will call them focal seizures. They may begin in just one part of the brain. If they stay in one part of the brain and don't spread to the surrounding area, it may be a simple partial seizure. With a simple partial seizure, you're aware, you can talk, you remember what happened, you can describe seeing the ants on the side of your body. If it's a complex partial seizure, the seizure spreads a little bit, and at that point might involve loss of memory or loss of consciousness, and you won't remember the seizure. And then there are seizures which have, we call it secondary generalization, and that's when the seizure starts at a small area, then spreads to involve the entire brain, and you might have a generalized tonic-clonic seizure. Dr. Tatum has some pictures later on of some videos of some seizures, so you get to see what a seizure actually looks like. This is just a picture of a generalized tonic-clonic seizure. The old term for that is a grand mal seizure. There's a tonic phase when the muscles tighten and stiffen, and there's a clonic phase when the body actually jerks. This is compared to an absent seizure, which is also called a petit mal seizure. Petit mal is an older term. With a petit mal seizure, the patient or the child is typically perfectly awake and alert, and all of a sudden, for 5 to 10 seconds, will space out, may flutter their eyes. Those 5 to 10 seconds are lost to the patient, and after those seconds, the patient returns to full awareness. Those are just some examples of different types of seizures. How common are seizures? And this is interesting. 10% of the population at some point in their life will have a seizure. It's most common in young children and in the elderly. And the highest incidence is actually under age 2, probably because a lot of febrile seizures at that age group. But so seizures themselves are common. Now, seizures should be distinguished a little bit from epilepsy. Epilepsy is a very common, probably the most common neurological condition, which is characterized by recurrent. Recurrent means more than one. Unprovoked seizure. Unprovoked means normal blood sugar, normal fever, no obvious cause for the seizure. When you have a pattern of seizures, when you have recurrent seizures, then we use the word epilepsy. And some doctors will say seizure disorder, some will use epilepsy. Sometimes that's just a little bit of wordsmithing, but it's all about the same thing. So one seizure all by itself is typically not considered epilepsy. And what's confusing about epilepsy is there are many different types. We went through the slides of different types of seizures. There are also many different types of epilepsy. How common is epilepsy? Now remember, 10% of the population will have a seizure at some point in their life. 1% of the population has epilepsy. So in the United States, there are 3 million people, and it can start at any age. This is just a slide of the Jaguar Stadium. This is obviously its stadium is full, so it's not a Jaguars game. It's probably the Florida-Georgia game or a monster truck show. But I think the Everbank Stadium holds 80,000 people if it's full. So if it's that many people, 10% or one section will have a seizure at some point in their life. And 1%, perhaps the blue area, will actually have epilepsy. So if you go to a Jaguars game or the Florida-Georgia game, and there are 75,000 people, probably there are at least 700, 800 to 1,000 people who actually have epilepsy. So it's a very common disorder. There are many causes of epilepsy. This slide talks about all the different possibilities. Some of these are very rare, and some of these are more common. In children, we see a lot of idiopathic epilepsy, and we'll talk about that again in a second. Other common causes might be brain trauma, so if they've had a car accident or a head injury, they may, 1 year or 2 years later, actually have seizures from that. Everybody worries about a space-occupying lesion, which is like a tumor. Very uncommon in kids. In the elderly, we worry a bit more about that. But there are a lot of different causes of epilepsy, and the neurologist's job is to define, okay, you had a seizure, why did you have a seizure, and do you have epilepsy? And for that, we use MRI scans, CAT scans, and EEGs, as well as talking to you and trying to examine the patient. The causes of epilepsy that I see most commonly in child neurology are typically idiopathic. And the other word for that is cryptogenic. So idiopathic is a way of saying the doctor's an idiot, patient's pathetic, but it really means that there's no identifiable cause for the patient's epilepsy. We know that there's a neurochemical imbalance, we know there's an electrical problem within the brain, but the patient is otherwise healthy and neurologically normal. You do a CAT scan, MRI scan, you don't see any lesions, the patient has a normal exam, but nevertheless they've had one or more seizures, and in that case we call this idiopathic. And that's actually very good. Some parents come to me and say, my child's having epilepsy, there has to be a reason. Why is he having seizures? And the good answer is there's no obvious reason. And sometimes that could be genetic, or sometimes it could just be he was born with the tendency. But that's actually the best type of epilepsy there is, because that's the kind that's typically outgrown. So we actually like the idiopathic epilepsies. Cryptogenic is also kind of a medical term that means there's a hidden cause, we just can't find it on an MRI scan. The other term we sometimes use is an epileptic syndrome. And an epileptic syndrome is a disorder that we characterize by signs and symptoms of the patients that occur together. This might include the type of a seizure, like an absence seizure. It will include the EEG findings, and some syndromes have a typical EEG pattern. The cause of a seizure, perhaps idiopathic. The age of onset, infant, elementary school child, or a teenager. And the course, or what happens over time, and how well do they respond to medications. These are the more common epileptic syndromes, and when you see a neurologist or an epileptologist, we try to see if we can't put you together in the syndrome. If you can say you have a syndrome, then we can predict what's going to happen a little bit better. There are benign syndromes and malignant syndromes. Benign syndromes tend to be the ones that are easily treated and will be outgrown. The malignant ones are the bad ones. These are the ones you really don't want to have. The more common ones are infantile spasms and a rare condition called Lennox-Gastaut syndrome. The benign ones, which are fortunately more common ones, there's Rolandic epilepsy, occipital epilepsy. The Rolandic epilepsy, it comes from the Rolandic fissure, which on the diagram of the brain was one of the areas that I can go back and show you. Absence epilepsy, or the absence seizures, and there's a condition called juvenile myoclonic epilepsy, which begins in teenagers where they have myoclonic seizures. These are ones that we can predict to the parents, tell them what will happen, and usually they're easily treated with medications. The malignant ones are difficult. So let's talk about treatment briefly here. So in the medieval times, they would, do trephination, I think, where they would, put a knife in your head and take out all the evil spirits causing your epilepsy. Fortunately, we now use predominantly medications to treat epilepsy. For the most part, we use medications. If medications don't work, we'll talk to you about epilepsy surgery, and that's a discussion Dr. Tatum will have with you later on. Ketogenic diet, also a discussion later on this afternoon, which is a very specialized diet. The VNS, which is the vagal nerve stimulator, which has been around for about 10 to 12 years now, is an option, and one of the representatives outside can show you some examples of that. But a lot of what we do is education to the patient, to to the family, school, and society like we are now. So it's medications and then some non-medication options. This is a nice diagram showing you just kind of what's happened with anti-seizure medications through the years. In 1860, bromides first came out, and we don't use bromides anymore because they had a lot of side effects. Phenobarbital, which we still use predominantly in young babies, came out in 1910, so it's been around for almost 100 years now. Dilantin, phenytoin, became available in the 1950s. Ethosuximide, Zerontin, still probably the drug of choice for childhood absence epilepsy. That came out in 1960, and it's still the drug of choice. These other medications, carbamazepine, valproic acid, and about 1990, Febamate came on the market, and in the past decade, there's just been, I can't count them all, 12 medications that have been released by the FDA to treat epilepsy. Most of these you may have heard of before. Lamotrigine is very commonly prescribed. Tagabine, not so much. Topiramate, commonly prescribed. Levetiracetam, which is Keppra, probably the most commonly prescribed medication these days. Zonisamide, oxcarbazepine, pregabalin, rufinamide. Lacosamide came out in the market about 2 years ago, and clobazam, which has been available in Europe for a long time, got approval in America about a year ago. And the most recent medication is ezogabine, which got approval but is not yet available on the market. So that's just what's happened with our technology with new medications. And we can talk, are the new medications better than the older ones? Are they more effective? And that's a good discussion we can have later on. How do neurologists know how much to give? Parents often ask me, how much Tegretol, how much Keppra should you put my child on? And these are kind of the general principles. And this is kind of like taxes, you give as much as necessary, as little as possible. So when I put a patient on Keppra, you want to give them enough to stop the seizures, but you don't want to give them too much because you might have side effects. And that's a really tough balance because it's hard to measure. It's hard to know what's enough because the only thing you can measure is a seizure, and as we've seen, seizures are scary and frightening, and you don't want to see a seizure. And then we usually start low with the medicine, and we go slow. Start low, go slow. That's our mantra. Start off on a low dose of a medication and gradually advance it every week or 2 weeks till you get to probably an average dose, and then we wait and see what happens. We usually increase the dose if the child continues to have seizures until we see dose-related side effects. These are side effects that occur as I give more and more medicine. If I give anybody too much Dilantin, I can make them sleepy, unsteady, dizzy. That's not our goal. Almost all the seizure medicines can do that. They can make you sleepy and dizzy. They can affect your mood. They can make you off balance. We have to carefully titrate that dose so you don't see those side effects. But those are the ones we look for, and we see those. We know we have to stop and back down and think about another option. What is the ideal AED, anti-epileptic drug? Well, this is the mission impossible because there really is no ideal anticonvulsant medication because it would be 100% effective if it was ideal, and even the newer medicines are not 100% effective. They're probably 60% effective, 70% effective. There'd be no toxicity. There'd be no side effects. And every medication has the potential for toxicity. It would be no drug interactions. A lot of patients are on multiple drugs, either blood pressure medicines or diabetic medications or other anti-seizure medications, and there'd be no drug interactions, and that would be the ideal drug. It'd be non-obtrusive therapy, so it'd be once a day or twice a day. Taking a medicine once a day or twice a day makes anybody feel different and like they're not normal. So we want to give a medicine as little as possible. And none of them are really once a day. Most of them are 2 or 3 times a day. There are a couple one a day out there, but they're usually brand only and more expensive. And it would stop seizures, and it would prevent epilepsy. And the anticonvulsant medications don't really, they may stop seizures, but as far as long-term epilepsy, it may control it, but it's not been proven that it actually prevents epilepsy. So that's the ideal drug, and it would be free. And we know they're not free. So does epilepsy go away? Well, typically it can be controlled relatively easily in about 2/3 of the patients. 2/3 to 3/4 neurologists can control the seizures with the medication, maybe the first medication or the second medication. Typically, we treat with medications for 2 to 4 years of seizure freedom before we talk about stopping a medication. So when patients ask me, how long will I need to be on Keppra? The answer is typically at least 2 years, and it may well be more, assuming they tolerate the medications and there aren't any side effects. But our goal typically is 2 to 4 years of seizure freedom before we stop medications. And that may be based upon the patient's age. If they're a teenager or driving, that's going to be a big conversation we have with the parents. Most childhood forms of epilepsy are outgrown by adulthood. So children who present with epilepsy at age 6 or 7, most of them go away by the time they're a teenager. When they start as a teenager or as an adult, the prognosis is less optimistic. And the best prognosis, this is the good type of seizures to have, is the idiopathic ones, no known cause, childhood onset, so elementary school age typically, and controlled in the first year with our first or second anticonvulsant medication. That's the good prognosis. That's the good type of epilepsy to have. What do you do if the seizures don't stop? Well, unfortunately, 10 to 25% of patients have medically intractable epilepsy. And that's the ones who don't respond to the first 2 or 3 medications. And you saw in that diagram with the development of new medications, there are probably 15 medications that we can pick from. But if they have not responded to the first 2 or 3, then we call those medically intractable. And then we have to think about our options. And the options are try another medication, and again, there's about 10 we can pick from, or think about non-medication options. And that's a discussion we'll have later this afternoon with a special diet called the ketogenic diet. You can stimulate the brain directly by putting electrodes actually on the brain, and that's on the way for FDA approval. And there's already indirect stimulation of the brain through the vagus nerve, which has again been available for about the past 10 years. And then epilepsy surgery. Dr. Tatum will talk about epilepsy surgery later on this afternoon. Typically, if you're a candidate for epilepsy surgery, we can define one part of the brain where the seizure is originating from, and if that area can be safely removed without affecting memory or motor function, we give you the option of surgery, which could potentially cure you of your epilepsy instead of just controlling it like medications do. So that's something we always look for. Are they a good candidate for epilepsy surgery? Why do we treat seizures? So this is really important. So why do we treat them? Because they're frightening to experience and to witness. And even though I've probably seen myself, hundreds of seizures, every one I see is scary, and it's a frightening thing to witness. So we try to stop the seizures for that reason. They're embarrassing the child. Have a seizure at school, in the middle of the classroom, incontinence, all your friends seeing you is very embarrassing. So it affects the quality of life. As they get to be older and be a teenager, we're worried about socialization, driving, employment, and insurance. So these are big issues, and the EFA has been very proactive in these issues. But the goal of treating epilepsy is to minimize the effect on growth and development. So that's the second part of my talk, is kind of the effect of growth and development with epilepsy. So when I saw this topic from Danielle, I tried to pick, kind of the top 3 questions about growth and development that if I was a parent, I'd want to ask. So I want to know, do seizures affect brain growth and development? Do the medications that we use affect brain growth and development? And lastly, what impact of epilepsy on a child's learning, emotional well-being, and social aspects? So those are the last 3 questions we're going to talk about. Do seizures cause brain damage? Very common question, Dr. Sheth, we get this a lot. My child had a seizure, did it do anything? There's a short answer and there's a long answer. The short answer is no. We don't worry about a single, brief, isolated seizure. But there's a lot of uncertainty in medicine. So perhaps the long answer is it's extremely unlikely. Again, medicine is not precise, but we don't, as best as we can tell, there is no damage from a single isolated seizure. That child will have any measurable brain damage, and again, it's hard to measure brain damage. There aren't good tools for that. MRI scans and EEGs are helpful, but don't measure it on a microscopic or chemical level. After a single seizure, so what happens after more than one seizures, 10 seizures, 100 seizures, does that cause brain damage? And there's some data to suggest that perhaps does cause some changes in the function of the brain cells. There's some animal models that do reflect that. And then if that seizure is prolonged, less than 30 minutes, and any seizure is, the person who's witnessed is prolonged, but to neurologists, we tend to use a cutoff of 30 minutes. So short answer is no, but there's some complexity to that. Do seizures cause brain damage? How much should I worry about my child having a seizure? Well, I try to be, optimistic with parents, and I say, not very much. But you need to have a plan. You need to have a seizure action plan. You need to know what to do if your child has a seizure or your spouse has a seizure. You need to have perhaps emergency Valium available. You need to have the school know what to do to call 911 if necessary. But you need to have an action plan. You need to take your medications as prescribed. The most common reason medications don't work is because patients don't give them. So, you can control that. And keep your doctors informed. Follow the recommendations and let them know if you're having problems. Let them know if you're having side effects and if you're having seizures. So we take it seriously, but we try not to worry too much about a single isolated seizure. But there are some areas that you can control. And these are the things I tell parents. You need to focus on what you can do. So, if they're in the water, swim with a buddy, have a buddy system like you do when you're scuba diving, and make sure there's a lifeguard. Most lifeguards are teenagers looking around the pool for to socialize. May not be watching your child, so make sure they have a buddy who's with your child swimming. You can control that. Wear your seatbelt. You can control that. Make sure the child wears their bicycle helmet. And parents ask me, is it safe for them to play sports? And this is an interesting thing that I read, that it's where the bathroom is more dangerous than an athletic field for a child with epilepsy. So if a parent asks me, can my son play soccer or football or lacrosse, I think that's important that they do those sports. It's important for socialization. They're usually wearing protective headgear. There are multiple adults around. So usually I encourage athletic participation. But, the bathroom is more dangerous than being on a baseball field, because that's where you have a seizure with the door locked and you hit your head against something. That would be bad. Another tough question. Do anti-epileptic medications affect brain development? The short answer, again, is no. But the long answer is all the medications have potential to affect the brain. They all have psychological effects and can affect attention, memory, and affect mood. Sometimes that's a minor problem. Sometimes that's a major problem. And we have to monitor that. It's not always easily measured. A young child might not be able to tell the parents if they have a problem with their memory. An adult might. Medications like phenobarbital and benzodiazepines, which are typically Valium and Klonopin, they really will affect your mood and memory. And we use those only on special occasions. We have less of a concern with the newer medications, but almost all the medications given in high dosages, and particularly when we use them in combination, have the potential to affect your mood and your memory. Our goal is to get the best seizure control possible with the fewest side effects, and that's a balance sometimes. Do medications affect brain development? Well, this is one area where we know medications can affect the brain development, and that's teratogenicity. So this is in the womb, mothers being on anticonvulsants while they're pregnant. We know that it can cause defects like spina bifida, monomeningocele, facial defects, cleft lip, developmental problems. The ones that we most commonly worry about are the older medicines like valproic acid, dilantin, and carbamazepine, but none are completely safe. And we're very cautious in women of childbearing age when we use these medications. Fortunately, in child neurology, this isn't a common issue for me, but in adult neurology, it is. And we encourage pre-pregnancy planning and folic acid supplementation if the desire is to have a baby. So we know it can affect the development in a premature brain. Does good seizure control guarantee a normal life? And unfortunately, it doesn't. Even if you're seizure-free, there's still an impact on you. Many patients have problems in school, marriage, employment, and interpersonal skills. So as a child develops epilepsy and goes through the adolescent years into adulthood, it affects them. Even if the seizures are well controlled, it affects their life. It's a complex disorder. It can affect learning, academic development, emotional and behavioral, and social. Lisa Cox, a psychologist from Nemours, who's here this afternoon, and she's tested many of our patients for all these issues, and particularly learning difficulties. Children with epilepsy are at greater risk for learning problems. They have difficulties with attention, concentration, memory, organization, achievement in school, and fatigue. A lot of this is variable, may depend on the child's cause of the epilepsy, may be affected the medications, maybe because they're missing school, they may be having seizures that are subtle and not being picked up on, like absence seizures, which are sometimes so brief that a parent may not realize they're having them. That will affect your ability to stay on task. And postictal, which means the time after a seizure. If you have a convulsive seizure, maybe a day or two before you fully recover. And for that day or two, you may be fatigued or tired or have